Hello, everyone, and welcome to another edition of the Eddrick Show. I am your host, Eddrick Jerome. This is the place for intelligent conversation with interesting people. Go ahead and hit that subscribe button, drop us a like, leave a comment. Let me know how I'm doing as I continue to bring you interesting content each and every week. Very, very special guest. Not only is this gentleman doing some amazing things in the world of healthcare, he's just a really down-to-earth brother, somebody I've known for a while, have a lot of respect for and admiration. And so let me get into his lengthy bio because he's
Oh,
doing
no,
a
no,
lot.
no.
He's doing a lot. I want to introduce Dr. Ahmad Garrett-Price. He is the founder and president of GP Health, a proactive preventative health practice platform focused on prevention and lifestyle modification. Dr. Garrett-Price is a board-certified family medicine physician leader with extensive experience in large integrated health systems and 12 plus years of practice experience in the primary care arena. In addition, Dr. Garrett-Price has been at the forefront of developing and piloting some of the first system-wide virtual health offerings and leading the first membership-based hybrid direct care model for the largest nonprofit health system in Texas. He is a proud graduate of Morehouse College and the University of Texas Southwestern Medical School, and he's passionate about constructive innovation and forging a proactive and preventative approach which can be more sustainable to health and well-being. Dr. Garrett-Price, welcome to the show.
Eddrick, thank you for that gracious introduction. I'm happy to be here. I appreciate you having me. Love what you're doing with the show, and thanks for making space for me on your platform for sure.
Of course, of course. We've got some exciting things to talk about, so let's get right into it. You have started and founded GP Health. Tell me about GP Health, the motivation for starting and beginning this practice, and what are the goals and objectives of this groundbreaking innovative health system?
So GP Health is a primary care service and platform taking a proactive and preventative focus to healthcare. It's our belief that the power of health and longevity really resides in how we live our daily lives. So we really designed a practice, right? Medical practice, but also this accompanying platform, be that technology or a trusted ecosystem of resources, think a dietitian or a health coach, to really shepherd and move our patients to, or I should say, our members to better health, better quality of life, therefore better health outcomes. And so it's something that I'm passionate about. And you've known me for a while from prior practice, in that, we're always looking to innovate and move healthcare forward to a certain degree. And so the origins of it really kind of lie in the beginning of the story, and just kind of has a lot to do with my upbringing and kind of my experience in healthcare. So that's kind of who we are in a nutshell. And obviously we can get more granular here.
Sure. Well, on that point, let's talk about your upbringing because your father was a physician as well, and so you've seen the large practices, the small practices, the community based med. You've have a lot of experience in different types of systems. So how are you bringing that experience to GP Health, and how does your background play a role in what you're doing now?
My father was a small town physician from the small town in East Texas, think 30 to 40,000. That's kind of all I knew when I grew up. We spent a lot of time around his office. He was a small town doc. I should also say my mother was a nurse, so she helped him run that practice. And so that really formed kind of my idea of healthcare and medicine as it was moving forward at the time. And then, he got called to do a bigger office and a bigger practice in Dallas. And so we ended up moving to Dallas. But that memory of kind of small town medicine where you may get paid in casseroles or farm fresh eggs, stuck with me. And I said, wow, he's making a difference. I didn't quite understand what it meant to be a physician then. But that was like planted the seed for a lot of what I do now. And so he went to Dallas, larger practice, managed care for all those of us who are in healthcare was starting to take hold at the time. So the private doc, private physician was being kind of folded into large groups. And so he went into a large group in Dallas, ended up graduating high school here in Dallas, just south of Dallas, was a student athlete at Morehouse College, played soccer, obviously did what I needed to do academically. And I say that to say that that's also an important part of the story, in that I guess being a student athlete really taught me a lot about kind of time management and actually being a professional, because you almost had to be a professional before you were a professional. And I was at a school where academics and scholarship were valued over athletic achievements. So yes, I would have games on Saturdays, but you had to take an exam on Monday, no questions asked. So it really started to, in terms of time management, what it took to succeed. And obviously you have to achieve academically at a certain pace. So that laid some groundwork as well. Fast forward, went to UT Southwestern for medical school here in Dallas. They have a distinction for being foremost research institution, was a top 10 medical school at the time. And so a lot of good exposure, trained at Parkland Hospital for a bit. And then I went to medical school thinking that I was going to be a surgeon or anesthesiologist. And, up until maybe my third or fourth year in medical school, I was doing that. And so I ended up doing a rotation with a family doc of all folks, who was a military doc, Air Force. So we actually did a lot of the Air Force physicals for the pilots. I was like, oh, this is really cool. His office was like a flight museum. And then one day a patient comes in, and I think she was like, I would say mid-30s. And she was like, hey, Dr. Allman, and rest in peace to Dr. Allman. She's like, oh yeah, Dr. Allman sees my mom and he delivered me. I was like, delivered? And at the time I didn't know. I was like, okay, so family docs can deliver babies. And I ended up delivering in, when I went to residency. And then I saw this whole arc of care. I was like, wait, so he's seeing mom, dad, he sees her, he knows their family history. He's clearly big in this community. And so it instantly took me back 20, 30 years, right, to where my father was. I was like, oh, this kind of resembles that. And I was like, I was looking for this and not knowing I was looking for it. So immediately I was like, this is what I'm going to do. So I do my family practice residency in Houston and Conroe, get to be chief resident. And when you're chief resident, you start educating the medical students, you start educating the residents, but also you start getting exposed to the business of medicine. So it's not just this clinical practice anymore. So I start to get a more granular sense of how my industry actually works. And so there were some eye-opening things there. And so you start to form some other opinions and say, okay, this is much more than me seeing patients in an exam room. And I then had the opportunity to go out to Kaiser Permanente of Northern California, which was a pivotal moment in my career. And I'm leading up to kind of GP Health. And that was a pivotal moment in that, the Affordable Health Care Act was being developed. A lot of what was happening in Kaiser was being attempted around the country, but folks weren't necessarily successful. And so I like to think of my time there, which I'm grateful for, as almost like this fellowship in integrated care delivery to a population at scale. Because before I had seen this, now I'm seeing this. We're talking about an area where you have 80, 90% market share. And so it was efficient, obviously high quality metrics, and there was a systematic approach to doing this. And so from that, and not only that, they had embraced technology at the time. So we're talking circa 2010, 2011. So now when we talk telehealth and these sort of things, it seems like normal. But back then, there were only a few systems really embracing this virtual care world. And so I got into my career, really loved what I was doing, but I quickly saw, what happened with the ACA is a lot of people got healthcare coverage, and then they started coming to the doctor. And as a physician, I was like, whoa, a lot of people coming to the doctor who haven't seen a doctor. But also what I started to see is that these folks are sick, right? And so maybe the approach of sick care may not be the best approach in the long term. So it kind of whet my appetite. I'm, younger guy, fresh out of residency. I'm always green and looking to do things well. So I was like, there's got to be some other ways in which we could approach health and care, or care delivery. So I, had this idea of like, okay, we have to maybe go further upstream. And then I got approached by a system here in my home state. We got to offer that opportunity to build out this more, how should I say, holistic, novel delivery care model And they happen to be the largest system here in Texas. And so I was the lead physician. They were implementing the electronic health record. They wanted to get some virtual care things spun up. So this automatically kind of whet my appetite. And so in that particular practice, I had more time with patients, like 60 minutes. We had
and that's key. I'm sorry to interrupt, but time spent with patients is a metric that is one of the most dissatisfying metrics of patient care relationships with their physician is time spent. So you had 60 minutes, which is an eternity in primary care medicine. So speak on that a little more, man, about how that's better not only for the patient, but for the physician.
Exactly. So, before every visit was 15, 20 minutes.
Right.
And so you're just drinking water from a water hose and a faucet that you'll never quench that thirst, if you will. Mm-hmm. Whereas in 60 minutes, one of the big takeaways from me was that I stopped doctoring so much from a clinical perspective and started teaching, right? And so what I saw was the 60 minutes allowed me to build trust. It allowed me to not just say, hey, you need to eat better, but now I can kind of delve a little deeper into that. Now I can talk about the importance of exercise. Now I can actually ask you how you actually feeling, like your mental health. Now we have time to make a big comprehensive plan. And not only do we have time, there's a support structure around that. And so I said, and here's another concept folks don't know is that like the root word of doctor, Latin docere, is teach or to teach. And so what was amazing to me is when I started teaching, I stopped prescribing as much insulin and blood pressure medications. So it's like what you start to figure out. And so my style as a physician was starting to adapt. So we're trained to treat. Maybe it needs to be teach, and treat, right? And so I started teaching and I said, okay, there is something here because people are actually getting better. And not only that, I've always been this person who embraces virtual care. So it's like, hey, now I can use this technology to reach you when you're not here. Again, we're talking 3, 4, 5 years before the pandemic. So to your point, the average time spent with the physician in this country is about 14.5 minutes a year. And that's if you go.
Right.
So 60 minutes visit is already kind of beating that metric. And that's some of the things that we're, obviously doing and implementing in GP Health. So I say that to say that this experience is kind of what laid the foundation where it's like, okay, more time, more teaching, health literacy, consistent follow-up, using the technology. How about we just design a practice like that and detach it, if you will, from the payment structure that incentivizes sick care and will incentivize, right, us to keep folks healthy. And so that's where a lot of, when we, the initial question, this is kind of where this bore out of. And so you're exactly right. I, as a physician, see that as key if we're going to achieve better health outcomes. Is like you have to at least have time to lay some sort of a foundational plan here.
You mentioned, the insurance piece, and my own opinion is this: even with the Affordable Care Act and things like that, that was pretty much sold as an insurance coverage plan, meaning more coverage for folks, more access to insurance, so forth and so on. So when you took that approach with GP Health, how do you bring in that really significant and complex piece of healthcare delivery, which is the insurance part of it? What are you doing innovatively around that piece as you get more and more involved with GP Health and GP Health is able to touch more people?
Yeah, so GP Health is really it embraces what we call direct care or direct to consumer care. So we're a membership-based platform, meaning that think of it as a gym membership. Okay. So it's a kind of monthly, quarterly, annual fee that can be paid monthly, quarterly, or annually. And what that does is, the way it works is that we bring our members in and we collect data about them before they even get there. So yes, medical, family, social history, but also this is also taken in the context of lifestyle, like what do you eat, how you're exercising, how do you feel? So it allows us to really curate and personalize this first visit, which is this 60-minute, what I call a comprehensive lifestyle exam, right? And so because I'm not incentivized, and I'll just stop and integrate what we're talking about insurance, because I'm not incentivized that, hey, I'm only going to get paid when I see 30 sick people today. You see what I'm saying?
Exactly.
Now we can spend the time that we need because this is a prepaid option, if you will, for well care. And I'm not incentivized to say, hey, I have to churn and burn through patients and do what I call assembly line medicine just to make ends meet as a independent private doc. So it takes the pressure, like that pressure from third parties leaves the room.
Mm,
So it's amazing how much you can accomplish when the relationship is direct.
hmm.
Me and you are collaborating on you getting better, right? And these are the tenets of you getting better. Now I know you personally because I have this data. So before you get there, this is a highly curated, personalized experience for you. We know what's important to you, etc. We'll address that. And yes, we'll talk about your diabetes and hypertension, but we're also going to talk about these factors that will actually keep you well throughout this engagement, right?
Mm.
So that's one way that the payment model kind of, you see, you can incentivize certain things or
Right.
de-incentivize certain things, right? And so we conduct that visit. We have set follow-up visits throughout the year, whether you're well or not. They're video visits, much like what we're doing now. So
Hmm.
you have the convenience of just kind of staying at home. But by the time you leave that 60-minute visit, there's a wellness plan, preventative plan, there's some health literacy rolled in there. And now you have a clear line of sight to what better health looks like. And this is just kind of what we're seeing early on. And we obviously are going to try to keep you on track throughout the year with that. And where the platform piece comes in is that, look, we can tell you what to do, but we also need to probably provide some support around that.
Right.
So again, talking about payment models, that's usually not incentivized in something like healthcare. You're only paid when somebody is in front of you and it's an episodic thing, right? So now, when you have true value based care wrapped in, it doesn't matter when or how we're getting paid from this third party. We can just do the best thing for you to get the best outcome. And now we have a technology platform that will plug these goals into. And essentially, between these visits, you now have information to interact with. This tech is going to induce a positive behavioral change. It's going to prompt, it's going to remind you of the certain things that we've talked about. And so you're just not left out in the dust, if you will, right? So I'm drawing comparisons here because most of the time, right, you do not have this type of arrangement because the payment model does not incentivize for this. And quite
Right.
honestly, these things are not paid for, right? Supportive technology, right? High touch virtual care, um, literature, health literacy. Like we don't incentivize, payment models is not incentivized for, how should I say, well care, if you
Right.
will. They're more
Right.
incentivized for sick care.
Right.
So
No,
it's
it
flipping
makes,
a lot of that on its head.
yeah, it makes sense, and it's a less I guess institutionally, how can I say this? It's a less stressful approach, I would think, because patients, in full disclosure, I won't necessarily know, doesn't matter which healthcare system I work for, but yeah, my I worked for years in the healthcare system, at clinical
Mm-hmm.
operations, so forth and so on. um there is a stress inducing aspect of insurance companies, when the patient's in your room and they've made the copays and okay, is this covered? I mean, so you're kind of taking that away from the interaction and the delivery of care, because that's massive. There are folks who won't go to the doctor because either they have a large copay or they this and that, which is that stressing aspect, which prevents people from getting the care they need. So it looks like you're addressing that aspect as well.
Yeah, so we're addressing that, and that's why in a membership, it's like you can have insurance, or the folks who don't have insurance, everybody can come to the same place, right?
Mm-hmm.
And if you
Mm-hmm.
do have insurance, what we do, I think of it as like, car insurance, right? Like, or house insurance. When you need it, you use it. So in this case, for us, when you need labs, you use that. You need imaging, you use that. You need to go to a specialist, that's where you use it.
I
But
see.
these very basic maintenance, not even basic, but these more fundamental aspects of keeping you healthy, we're going to do that here since this model doesn't necessarily pay for that. But
Sure.
I have observed that the membership opens up doors for those who otherwise just would not engage. I mean, we have 40, 50 million uninsured folks in this country. And a lot of them are not who we think. It's not the indigent. It's not always the sick and shut in. It could be an entrepreneur, a business owner, a C-suiter, right? And so they are looking for an option beyond what's currently available. And we, as an industry, have to start to provide different access points for people and kind of meet them where they're at.
You referenced technology and virtual care, and telehealth. Even though the pandemic forced people to adopt some aspects of telehealth in many ways, it's still a relatively uncharted area. I mean, it's still not fully developed. So, what are some of the telehealth challenges for both patients and physicians and healthcare providers? And then where do you see some of the opportunities for further development and growth in this area?
So challenges to me are much like what we just talked about, payment, right?
Okay.
Think about it, like this is a tool that has always been there, but we didn't use it because we weren't reimbursed.
Right.
And the only reason we're using it now is because with the emergency orders that now it's reimbursed on the same level of an office visit.
Mm-hmm.
So first of all, it has to be incentivized. So the challenge is getting it paid for, because the not so dirty little secret is if it's not paid for, it will go away,
Mm-hmm.
like in some format, right? So that's challenge number one to me. Another challenge is that making sure it's actually equitable and accessible for all populations. In terms of broadband service, in terms of connectivity, in terms of how we deliver it, but also making sure it's not just a tool for those who it's accessible to. So if it's going to be there, we all should have access to it to a certain degree. Um, and so those are, to me, two of the major challenges that I'm seeing, with telehealth. Now, it's funny because to me, the benefits outweigh the challenges, and the benefits are that, you know, high touch, high access care. Now, if you have diabetes, I can just call you about that. You don't necessarily have to come here. Or
Right.
for those who are from certain populations and transportation is an issue, man, we can manage your blood pressure with the phone call now, right?
Mm-hmm. Mm-hmm.
And same goes for acuity care or quote unquote urgent care type of visits. If you have, say, strep throat or sinuses are acting up, like these are quick, high quality touch points that you can access here moving forward. So it is an access point and almost an extender of care if we use it correctly. And so I think the benefits outweigh the risk. And I should also say one of the challenges is, as a physician, I've always done telehealth. It's always been a part of my career because of that's just my career design, whether the organizations I was with or independently. There's a certain skill set needed, right, and kind of training to still get the necessary information so this doesn't become this risky endeavor. You still have to have good bedside manner, even though you're theoretically talking into a screen and somebody's not in front of you. So I would say one of the challenges is just training the workforce so it is a smooth workflow, but also where there's empathy, there's care,
Mm-hmm.
and good, how should I say, virtual bedside manner, and it doesn't just become much like an in-office visit in some places where it's purely transactional. So, there are challenges there as well, but I think it's like with any tool, as we get up to speed, as we use it more, we'll get better at using it for sure.
Hmm. If I can, one more quick technical question before we move into
Yeah.
more of the care and the actual benefits that people can find for their health.
Mm-hmm.
One of the things we had talked about, prior was the aspect of healthcare information privacy and ensuring that
Mm-hmm.
healthcare records, which are some of the most private records, if not the most private records that an individual can have. I would imagine setting up your practice in this way, you put in some pretty extensive
Yep.
and rigorous rules and regulations around privacy and protecting healthcare. So healthcare records. So maybe you could speak on that a little bit as it relates to GP health.
Yeah, so I think for us it was always because our chief operating officer has a MBA, Masters of Public Health. We both been in healthcare. To your point, privacy, data having things be high tech, HIPAA compliant, because what we're seeing now is that at times people are not taking the necessary precautions with the data, with the way that it's delivered. But I think those of us who come from a more traditional healthcare background understand the importance of doing so. So I think moving forward, any organization, whether you're a startup, whether you're a novel delivery care model, will need to meet the standards that are required for such sensitive data, but also sensitive interaction. So I think you're exactly right in that we need to, this is a part we need to color in the lines, right?
Mm-hmm.
We need to make
Mm-hmm.
sure things are safe, things are not being shared, and that there's no, I read your script, there's no additional intent, to this data that's so valuable, right? And I think eventually, patients or members or whatever word we would call folks who seek healthcare services in the future are probably going to have a lot of this data themselves. And we mentioned this where it's more of a personal thing. You have it and you share it with the organization. I just don't think that we're quite there yet.
Yeah.
So we as organizations have to be good shepherds, if you will, of the data and some of the things that we transmit and receive.
Mm-hmm. I want to move now into more of the actual healthcare benefits to
Mm-hmm.
populations. And so one of the populations I want to start with is I know you always advocated and been a big proponent of communicating and with African American men and African American male population. Because there at times there is a disconnect between healthcare
Mm-hmm.
access delivery and African American men. So tell me about some of the ways that you are striving to ensure that some of the disparities we've talked about in care delivery for this population is happening so that African American men can get the health care they need, particularly the preventive aspect, which I think is key, and I know you do too.
Yeah, so I think that's a great question. And so we were very intentional in how we design things at GP Health. I mentioned these questionnaires and kind of going through that process, but those questionnaires are really designed to, take into, well, let me back up and say this. When you look at a healthcare outcome, about 20% is clinical care, about 30 to 40% is healthy behaviors, the other 50%, 40 of which is going to be environment and socioeconomic factors.
Hmm.
So our questionnaire, so what you should take from that is in its rawest form, when people think healthcare is like, oh, I went to a big healthcare system, I saw this, that's only 20% of what you need to do to live a long, healthy life, right? So automatically knowing this, having experience as a physician and delivering care, is that okay? What we're going to do from the very opening inning, right, is yes, we'll get health data, but we're going to get data about lifestyle and healthy behaviors too,
Hmm.
right? And we're also going to touch on socioeconomic factors like, do you have a home to live in? Do you have basic access to social services and that sort of thing? So these questions are asked from the very beginning before anybody even gets to us. So, and not to mention, we're acquiring more data points about preventative maintenance and things that you have done to keep yourself healthy. So automatically the equity and the access and some of these things that are really what I consider as a physician are probably more high yield for you are already getting asked in the very beginning, right? And so what that allows us to do is that first visit is very curated, it's very dialed in, but we also are able to practice from a point to where we feel that, okay, now we are confident that we have a better picture of this person, right? This is a 50-year-old African American male that hasn't seen a doctor, hasn't had a PSA, hasn't had a colonoscopy, right? And the guidelines say we shouldn't offer that for another 5 years. But based on the personal data that we have, we'll offer it now, right?
Mm-hmm.
So
Mm-hmm.
what we're starting to do is say, okay, now that we know you a little better, you should do your PSA, you should get your colonoscopy, and we should check for diabetes and hypertension and look at your cholesterol right here right now today and not wait on that. So a lot of this has to be intentional. I was on a podcast, I told people a lot of it is design, like designing for the end outcome, but also being aware of, as African American men, I think trust is a big thing for us in coming to see doctors. Usually it's I call them our chief medical officers in the household, which are our wives and our significant others that kind of make us show up for these visits. So we want to also acknowledge their Black women, their role in being the facilitators of health in our households a lot of the time. And so now that we know, hey, this person is at risk for this, well, we need to offer this even if it's not against traditional guidelines. I use PSA as a good example where traditionally we would ask at 50 to 55, but a lot of those studies weren't done on Black men. So
right.
We know that for Black males, this is usually 40s, early 40s. If it's going to happen, 40s, mid 40s. So we probably need to start checking in as opposed to waiting till 50 and 55, where we may be in a worse scenario. So again, the whole proactive preventative approach is something that we need as people, but also just specifically as African-American males. So I say that to say that what we're attempting to do is also deliver what I call culturally competent care, where, you know, what's right for Eddrick Jerome? Like, yes, we follow guidelines, but what's right for Eddrick at this point, at this moment in his life, based on his personal profile that he gave us? So we try to practice medicine and deliver care from what I call like an N of one. Like everybody's a one-to-one, right? And I think that approach really, when you start to bake in the equity, when you start to give access to people who traditionally would not go to see the doctor, and it's all built on a trusted relationship, you start to see some positive outcomes. And actually, instead of dread about health, what we're observing is enthusiasm about health now. Now I know what to do. And so when we talk about African Americans in general, when we talk about Black men, Black women, part of what is baked into what we do, a 60-minute visit, is education and health literacy, just returning to that point. As a physician, I cannot tell you how important that is for systemically marginalized and disenfranchised community. A little knowledge can go a long way. If you can teach someone how to fend for self and take care of themselves, especially from a health perspective, I'm not going to say, oh, they'll do the work for you, but it goes a long way. So health literacy is one of these things that, you know, yes, it's great to see a doctor. Yes, I'm happy we're delivering care. But I think what I'm most proud of is that people are becoming educated about themselves, their lives, their lifestyles, and what it takes to have a good health outcome for them, right? For them as an individual. So to your point, and I guess it's a long-winded way to say that health literacy is a kind of a tenet. And then we as Black males, I think if we understood the importance of good health, if we understood the importance of being proactive, preventative in terms of our approach, meaning don't let the illness happen at all, beat the illness before the illness beats you, or if you do have it, this is how you manage it, right? Just the education, and not just like, hey, go eat. Well, let me show you what you probably should do here. Or this is what exercise looks like. It's not that I need you to go be a bodybuilder. Just get up and walk for 15 minutes a day. So when people start to understand what they actually need to do to live a long, healthy life, you see them action that, and especially for certain communities, it's almost like a light bulb going off. So this health literacy component cannot be understated.
With the health literacy, I know you also are very well versed in advocacy in healthcare. And so maybe you can talk about that aspect of it, because they all kind of go hand in hand, the literacy, the training, the teaching, but also the advocacy. Can you speak on that?
Yeah, so I think the advocacy is to your point. I see health literacy and advocacy as almost under the same umbrella, and maybe even one thing. And part of the reason I say that is that when you know, you can advocate for self just a little bit better, no matter what the context that you're in. So I think that the way traditionally healthcare has been set up, where there's bias, there's systemic inequalities woven into it, that you knowing how to better care for self now makes you what we call, I keep using this term, kind of activated patient. And we've actually got good literature to show us that if you can go into an office where there's maybe bias set up against you, and you have questions, you have knowledge of maybe what you're trying to achieve, and not saying that it should all be on the patient to understand it. I think you should get quality care no matter where you go. You can a lot of times disrupt a poor outcome, a bias against you just by going in and saying, hey, these are the things I want to achieve, these are the questions I have, etc. So I think that these things, part of the reason I'm big on literacy, because I feel like I'm equipping, empowering individuals to be able to self-advocate, right? But we also, as healthcare professionals, have to say, okay, what are ways that we can weave this into our clinic visits, our way that we approach and deliver care, to where people can feel more empowered and knowledgeable about who they are from a healthcare perspective, because on down the line, as they deal with different specialists, this will come into play, or they deal with the system, this will come into play. And I've seen that, honestly, for communities of color, that can be the difference of good and bad outcomes. I've seen that in my own family, and we're a family of healthcare professionals. So no one is got to escape, inequities or biases. And so one of the best ways to do that is to become an advocate for self, advocate for loved ones, advocate for family members. And again, health literacy is one way that it looks, right? But also it could just be, hey, I'm going to go to a visit with the loved one and make sure that they're getting the necessary information from this visit so we can take the proper actions afterwards. So I see these things as being almost one thing, if you will.
Yeah. Quick public service announcement. If you have a loved one, make sure you have your advanced healthcare directive, make sure, or power of attorney, or that you've taken the steps proactively to have someone either speak on your behalf, or that you are able to speak on their behalf if something happens. So please, 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 especially in our community, go ahead and get those advanced healthcare directives, so that the system doesn't start making decisions for one of your loved ones and you're sitting there helpless. We have a few minutes left. You have another aspect of GP Health that I want to touch on, and that's you have a direct to consumer retail pipeline for supplements and healthcare related products. So you're going holistically about the services and products and things like that people need for improving health. So talk to me about how you came to develop that part of GP Health, and how is it going with that?
Yeah, so it's funny because what I found myself doing, the way that I've evolved as a physician is that when someone comes to see me, and even at GP Health, like, I'm not going to automatically start talking about your health issues. I want to know what you're putting in your body. Are you exercising? How's your mental health? Are you resting? Do you have social connectivity? And just overall, how do you feel? Because from experience and practice, those things have, and again, the data proves this when we talk about this health outcome pie, those things have a lot to do with how, like, even if I prescribe this medication, you're going to proceed or progress, right? And so what I found is that a lot of times now I'm trying to de-escalate medications. I'm trying to de-prescribe. I'm trying not to prescribe or escalate medications if it's not necessary. So part of that is saying, hey, I think folks should be on a multivitamin, especially African Americans, maybe vitamin D, vitamin C. So we were saying, if we're not prescribing traditional medications as much, we want to provide a service where folks can get medical grade products, nutraceuticals, if you will, from a reputable source that are greatly manufactured, and you're just not pulling them out of the shelf. So we wanted to provide that within our practice as a service. And we actually do. Our members have access to over 10,000 medical grade supplements and products at a discount, if you will, because they're a member of GP Health. So instead of sending you out, think of that as our in-house nutraceutical pharmacy, if you will, except this time, Dr. Price has prescribed 1,000 milligrams of vitamin C. Dr. Price has prescribed vitamin D3 at 2,000 international units, or we want you to take certain multivitamins to really, again, continue to optimize you from a health perspective, or we're giving omega-3s for cholesterol and cognitive fitness. So yes, it's a service. Yes, it generates revenue, but it's also one of those things where it's an all-encompassing thing, and it allows us to provide a higher level of service. So we're proud of that, and we're happy to offer that as a feature. And our members actually like it; they love it, and they've been shopping on it. And so yeah, it also allows me to kind of direct and not just say, "Hey, go buy this." It was like, no, we've got a great product here, and we can actually send that to you. You know, all orders are drop shipped. It goes right to the front door, you know, free delivery. So it's also like a service aspect to that as well. Because I found myself at prior practice saying like, hey, you need to go get all these vitamins. I was like, well, why don't I just have that here for y'all so you don't have to go? And it's much like a medication that you would send to a pharmacy. If we send it to the pharmacy, or if we just talk about it and we give you a written script, well, maybe you won't feel that. But if I electronically prescribe that, you'll go pick it up and take it. Same thing here, is that you're more likely to do these things if we just have it built in for you to automatically do. So it's also kind of one of those things where you observe the workflow, and it kind of works for us and our members.
Well, Dr. Garrett-Price, I want to thank you so much for coming on the show. Before we wrap up, is there anything we didn't cover for GP Health? Anything else that you want to let us know about? And then also, how can people get more information about you, GP Health, so that they can, take a look at it and see if this works for them?
Yeah. So our website is drgp.health. You can find me on LinkedIn. We also have our social accounts are active, and we have folks responding. So you can find us on Instagram at GP Health. You can find us. So the Twitter is kind of tied down. So those are the ways that you could reach us. And I would say in closing is like, yeah, we love what we're doing at GP Health. And proactive, preventative, a more upstream approach is going to be key to us achieving health, certainly in certain populations. But if not GP Health, we highly encourage you to be an active participant in your own health, your own longevity, because health is truly wealth in every sense of the word, and not just kind of monetarily. So we want our folks to be thriving and have the highest quality of life. And we feel that GP Health is a vessel in a delivery system, and it allows our members to achieve that. And already our feedback is that this is life-changing. It's beneficial. This is definitely different from what I traditionally get. So yeah, so we're excited about this.
As you should be. Well, Dr. Ahmad Garrett-Price, founder and president of GP Health. Again, thank you so much for coming on the Eddrick Show. And congratulations. You are literally at the forefront of a new model and a new approach to delivery of care. And I applaud you for taking the risk to put yourself out there, man, because I know it's not easy with a lot of pressures that come with providing healthcare. So thank you so much, and congratulations, because again, I think you are onto something. And I think as more people find out and discover GP Health, they're going to realize that this is a great alternative. So thank you very much.
Most definitely. I appreciate the space and the time, Eddrick. Love what you're doing with the show, and thanks for having us.
You're very welcome. You're very welcome. This has been another edition of the Eddrick Show. I am your host, Eddrick Jerome. As I promised, this is intelligent conversation with interesting people. Hit that subscribe button. Check us out on Spotify, YouTube, a host of online streaming platforms. Again, as I bring you this interesting content each and every week, thank you for tuning in, and we will catch you on the next episode.